Okay, so I think we'll start, guys. Hi to everyone, and welcome to tonight's webinar on PT and Duchenne with Doug Levine. For those who don't know Doug, he's a certified physio for Cure Duchenne and also co-runs the Duchenne Physical Therapy group, among many other things. He is quite literally, taught and been tirelessly involved in the community for many years. And, personally, as a parent of a kid with Duchenne, I think in Australia, in general, physical therapy as part of the core standards of care in Duchenne is really sort of under-emphasized and really underutilized. And I know from my personal experience with my son, it's just how important it is. So I'm very thankful and appreciative for Doug to be jumping on with us tonight and speaking with us. Now, I understand it's pretty early over there, Doug. So, thanks for getting up for us on a Sunday morning.
Absolutely.
And I'll hand over to you now. And just for everyone on the call, just be aware we will be leaving 10 to 15 minutes for questions at the end. And if you want to log them in the chat, and we'll get to you towards the end, providing this time. Thanks, Doug.
Yeah, Michael, Chrissy, thank you for having me. I really appreciate it. What we're going to talk about tonight is like Michael was saying, the role of physiotherapy and in the different stages of Duchenne. So we're going to look at, what can we do as physiotherapists when the child is walking, and then also how does that role change but become no less important when the child is no longer ambulatory. So just a little bit about me, just to kind of give you some context. I'm a physio in the US, and I work in a bunch of different environments. So I think that this is important because I think I can kind of lend a perspective from different environments. I see kids in the home, so I'll travel to them and go see kids in the home for physiotherapy. I also help run the neuromuscular multidisciplinary clinic that we have here. I'm from Austin, Texas, so help run our clinic that we have here. I'm also a school therapist. So here in the US, we also have therapists that provide that work in the schools, and they provide therapy in the school, but the focus is on having them be independent in the school, have access to the schools. So it's not so much like a pull-out type model, but working with them collaboratively with the school. And then I also work with Cure Duchenne. It's a nonprofit advocacy group here in the US. And I travel around and provide education to families, but also training physiotherapists in different parts of the US and other parts of the world. I've just recently been to India and Nepal, to various hospitals and teaching as well. So I try to, I think working in those different environments kind of helps because I can see things from different perspectives. So what we're going to be talking about today, briefly, just some objectives is understanding the role of physiotherapy in the ambulatory and non-ambulatory stages, but also understanding a little bit about those stages. So they're broken down also into different parts of the ambulatory stage and then non-ambulatory stage. So what do things look like in each of those stages? And then understanding like what an evaluation looks like for a child with DMD. What are we focusing on? Because the focus and the knowledge that it takes to work with somebody with Duchenne is very different than other pediatric issues. So, I also sometimes work with kids with cerebral palsy or spina bifida, and the approach with Duchenne has to be very different. And so kind of understanding why that is. And then establishing appropriate goals and also treatment strategies. What is a session of physiotherapy going to look like? And how are we going to work with the parents and educate the parents? So just some basics I know that there are parents on this webinar, there are physios on this webinar. So just to talk a little bit about Duchenne. It's progressive. It causes muscular weakness over time. Usually the kids are diagnosed at around the age, on average, it's around 4 or 5 years old, can be earlier, many times it can be later. And so some of the things that we're going to see, the primary impairments are weakness. That's what we'll first usually see. And you can see the muscle groups here that are usually affected first. It does affect the whole body. It comes, Duchenne muscular dystrophy comes from a lack of dystrophin in the body. So there's going to be weakness throughout the body, but we usually see it first in these areas: hip extensors, the gastroc soleus muscles, which are the calf muscles, and the back and the abdominal muscles. So first we'll see that weakness, and then we'll start to get that muscle stiffness. And then the secondary impairments leading from that is we'll start to get the guys will start to get contractures. And for the purposes of this webinar, I'm going to refer to guys because that is the most prevalent, but there are females that are affected as well, manifesting carriers, where you will see these symptoms in the females as well, but it's overwhelmingly the males. So secondarily, we'll see contractures, and then usually it'll start with the calf muscles, and then the hamstrings, and then the tensor fascia lata, or the IT band, which is on the outside of the thigh. Once we start seeing these contractures and this weakness, we're going to start to see compensations. So these guys are trying to do everything they can to keep upright, to keep walking, to keep doing all the things they're doing. And as certain muscle groups are starting to get weak, we're going to start to see compensations, and we'll talk about that. And then activity intolerance. So things get harder. Walking gets harder. Keeping up with their peer group gets harder. Keeping up with siblings gets harder. So they want to do things less. It just becomes more difficult. So what do we do with that, and how do we combat that? And then balance disturbance. As they start to get more weak, start walking up on their toes, the balance gets worse, and so they're at risk for falls. So the initial clinical presentation of it, like I said, they're typically diagnosed around 4 or 5 years of age. What are the first signs that we'll see? Because this is one of the things that we're doing in doing this education is working with the physios, but also working with the doctors to help identify this earlier. So it's been shown that the earlier we can identify this, we can strategize, and we can have interventions to prevent other complications. So what do we first see? Toe walking is very common. That's one of the first things that we'll see. Pseudo hypertrophy of the calves, so that's an enlargement of the calves. And typically this is it's pretty obvious. It's not like a little bit of an enlargement of the calf muscles, but typically the calf muscles are much larger. Sometimes in other muscle groups as well, we'll see this enlargement, but overwhelmingly it's the calf muscles that we'll see. Gower's maneuver, for those of you that are not familiar with that, it's when you ask a child, like if they're sitting on the floor or they're laying down on the floor, if you ask them to get up, it's the Gower's maneuver. It's a slower rise to stand, and then they will usually push on their thighs to they'll kind of use their hands to walk up their body. So pushing on their thighs and walking up to help get themselves up, and that's because of weakness. What we call a waddling gait. And so again, as they're starting to walk up on their toes more and get weaker, we see other compensations. So a lot of side to side movement, a kind of swaying of the back, and that's just things get tighter, things get weaker. They're trying to continue walking. So it's a fairly typical gait that we'll see with Duchenne. And then difficulties with stairs and running. And those are kind of for obvious reasons. Those are things that require more strength and more difficulty. So we'll start seeing those early on as well. So some general rules for activity, and this is more in the early stages when they're more ambulatory. We want to try to limit or eliminate the things that are going to provide the most stress on the muscles. So those are usually stairs, hills, running, jumping. These put the most stress on the muscles. Just backing up a little bit, we were talking about that there's a lack of dystrophin in those with Duchenne muscular dystrophy. What dystrophin does in the body is it kind of it holds the muscle fibers together. So it provides like a scaffolding for the muscles, so that when somebody without Duchenne, when we do heavy work, when we're running, when we're jumping, when we're lifting heavy objects, going up and down stairs, we get a contract and relax of the muscle, and the dystrophin holds everything together. And if we work our muscles to fatigue, those without Duchenne, if we work our muscles to fatigue and we get muscle breakdown, we rebuild that with healthy muscle. And the dystrophin helps, it's a protein that helps that rebuilding, help hold the muscles together. If you're missing dystrophin or you have a large lack of dystrophin, it causes damage to the muscle, and it kind of causes the muscle to sort of fall apart, and then calcium will leak into the muscle, and it just you basically replace this health over time, this healthy muscle tissue, with scar tissue and fat and fibrosis. So that's why you get this progressive weakness, because over time the healthy muscle tissue gets replaced with things that don't provide elasticity or contractile tissue, and you get less and less healthy muscle tissue and more things like scar tissue where there's going to be weakness. So that's why we need to be careful over the kind of the overall viewpoint, or the overall focus should be on limiting those things that are going to prevent damage. So stairs, hills, running, jumping. We don't want to do repetitive muscle work to fatigue. Again, that can cause muscle damage. And these guys just don't have the endurance to do those sort of things. When we're looking at the activities that the boys are doing or the men are doing, we don't want to just look at one activity, but we want to look at what are they doing throughout the day. So let's take the example of in the school environment, maybe we're limiting how far they're walking in one instance. So we're not, throughout the day, we're not having them walk too far in any one time, but we still need to look at the cumulative daily activity. So how many times are they having to get up and down from their desk? How many times do they have to get up and down off the floor? How much are they walking throughout the day? So we're looking at that cumulative daily activity as well, and then adapting that or providing modifications to limit that. Activities which are based on strength are not appropriate at any stage. There's fairly recently, in the last couple of years, there's more research that's going on in the physiotherapy community in terms of strengthening and exercise and Duchenne. So there's a lot more that needs to happen to try to determine where this plays into. But it's starting to show that some degree of exercise and some degree of activity, there's kind of this sweet spot, and that's varying for all individuals. So it's hard to say this much activity is kind of that sweet spot for everybody. But it looks like there is some degree of activity where we're maintaining mobility and limiting the breakdown of the muscle. So we still want the guys to be active. We still want them to be mobile. We still want them to participate in activities. We just need to be careful about the strengthening component. And then the physio and occupational therapy plan really should be focused on maintaining strength and improving efficiency. So maintaining what they have. As I was saying before, other diagnoses that pediatric therapists will work with, a lot of it is based on strengthening. Cerebral palsy, spina bifida, other types of diagnoses, we're working on strengthening. That's the guy's muscles or the people's muscles are weak, and so that's the focus. But as you can see, like we talked about with Duchenne, if you're going to focus on strengthening, you're going to do more harm than good. So it's really about maintaining what they have, educating the parents on what are okay activities to do, what do we want to try to avoid. And I think it's really the physio's responsibility to educate the families. This is why it's so important for us as physios to understand not just about what activities are okay and what activities are not okay, but underlying what's happening with the lack of dystrophin, so that we can properly educate the parents so that they can make good choices for their kids. And then this last rule, general rules for activity, we really want to focus on quality of life. That's so important. We can certainly focus on preserving the muscle, having these guys sit on a couch, not doing anything that's going to damage the muscle, but that's not a quality of life. So how do we balance mobility, keeping up with their friends, having a social life, going out and doing the things that the kids or the guys really enjoy doing, but how can we help the parents to modify those activities so that they're still having a social life, engaging with their peers, engaging with their siblings. And just some basic things, we were talking about that exercise can be important. It has to be individualized for every person. So walking, for somebody with Duchenne, let's just use an example of walking a kilometer. That might be very easy and not very fatiguing for one individual that's 6 years old. But for another individual with Duchenne that's 6 years old, that might be extremely difficult. So we need to assess, for every person, what do they need to be doing? What do they need to stay away from? What fatigues them? So really making it individualized. We want to stay away from eccentric exercise. And so that's basically, eccentric exercise is exercise where the muscle is elongated. So going down the stairs is an eccentric muscle activity. Going from standing to squatting is an eccentric muscle activity. So it's just basically where the muscle is still being worked, but elongated at the same time. The reason that we kind of talk universally about staying away from that is that causes the most stress and the most damage to the muscle. So also incorporating frequent rest breaks, whether it's exercise, whether it's at school, whatever it is, trying to avoid fatigue. So building in those rest breaks. And then if we are doing any type of exercise that does involve any type of strengthening, low loads, so not making it heavy work. So you can see on the bottom here, like a stationary type bicycle, an assisted type bicycle, aerobic exercise. So things in the pool, things like cycling are typically very good activities for these guys. So progression within the ambulatory and non-ambulatory stages of DMD. These are typically broken down by age, but again, it can be very varied per individual. But this early ambulatory stage, a lot of times the guys aren't even diagnosed at this stage. So that's a lot of times like 2 or 3 years old to about the age of 5 years old. And what we're going to see, well, and we'll go in a second in terms of what we're going to see at each stage, but that's the early ambulatory stage. The mid-ambulatory stage is approximately 5 to 8 years old. Late ambulatory or transitioning stage is about 8 to 10 or 8 to 12 years old. And that's when they're walking a lot shorter distances and falling a little bit more. And then you have the non-ambulatory stage, which is somewhere around 10, 13 years of age. And then that's a lot of times also broken down by the early, mid, and late non-ambulatory stages. So what do these things look like? This early ambulatory stage, very mild. A lot of times it's not even picked up by the physicians or by the physiotherapists. Usually we're seeing the kids in our clinic or we're going into the home. There hasn't been a diagnosis at this point, but they're just kind of delayed in their milestones. They're delayed in their sitting up, they're delayed in their walking. The average age of independent walking with somebody with Duchenne is about 18 months. So so usually we're seeing these guys for delayed milestones. So maybe there's not a family history of Duchenne. There's nothing else going on. We're not seeing that enlargement of the calf muscles or walking up on the toes yet, but they're just behind. Possibly falling more than their peer age group. They might be starting to have a little bit of difficulty getting up from the floor. So we might not see that Gower's sign yet, but they're just a little bit slower in getting up from the floor. And they may demonstrate other global delays, including verbal. So we'll see that a lot. There's a correlation between speech or verbal delays and Duchenne muscular dystrophy. So there might be a delay in this on the speech side of things. So if they're diagnosed at this early age, if we know that they have Duchenne at this 3 to 5 year age, what are we doing as physiotherapists and also as parents, because you guys play an extremely important role. I always tell parents, I might be seeing your child once a week or twice a week or in clinic, less than that. So it's certainly important what I'm doing with the child at this stage, but it's way more important what you're doing as the parent, because you're with them on a daily basis. So early on, it's very important to educate the parents on Duchenne. It doesn't have to be that the parents are experts or know every single aspect or component of Duchenne, but I want to give them an overview. I want to talk to them about dystrophin and the role of dystrophin. I kind of impress upon them the importance of knowing what their child's mutation is, so that if there are any treatments or from the pharmacological side, if anything comes up, I want them to know what their child's mutation is so that they can understand what's out there. But really talking to the parents early, educating them on the role of taking breaks, not doing things to fatigue. Your child is not lazy. They're not having these difficulties because they're lazy. They're exhibiting weakness. So just really understanding and at this early ambulatory stage, we don't have to go into the lifelong progression of things because that can be overwhelming. There are some parents that want to know everything from the beginning, but I kind of bring that information as the parents are ready for it. But just doing a lot of education in the beginning, activity modifications. So trying to talk to them about maybe what to do if the child's invited to a birthday party, or if they're in school, or these different activities where they're going to be doing a lot of exercise. How can we modify that so that the child still stays involved, but they're not, we're trying to limit the damage to the muscles. Certainly at this age, initiating a home program of stretching. Stretching is one of the most important things that we do from the physiotherapy side on DMD. So showing the parents stretching and what to do, and begin the use of night splints or AFOs, nighttime AFOs. They're called different things in different places, but we want to introduce this early. We don't want to wait until there's tightness. And what the nighttime AFOs do is they just wear them. Basically, they're braces for the feet that preserve the range of motion. So they're made of plastic. I am assuming that you guys have the AFOs there, but they're typically just used for nighttime. They're not used for walking as well. And so utilizing those, starting those AFOs for nighttime or during sleeping before the child gets tight. We want to stay ahead of that tightness. Really, really important. Once the child gets tight in the calf muscles, it's really difficult to reverse that. So we want to start that early, even before we see any tightness. And then introduction to those activities that are good for these guys and are not going to cause damage and are fun. So cycling, stationary cycling, swimming, just helping to come up with different activities. And then teaching, even at this young age, this 3 to 5 year age range, teaching the parents, but also the kids, self-awareness. So I know that that's a very young age to do that, but we can even start and talk to them about, hey, if you're tired, take a break. If you're playing outside, let's take water breaks. Let's sit here every couple of minutes and take a water break, get something to drink. So just talking to them and teaching them about, how does your body feel? If you're tired, it's okay to sit down. That's fine. Let's sit down and take a rest. So that self-awareness becomes, I think, more, I don't want to say just important, but it becomes easier for the kids at a later age. But even talking about this early, I think, helps a lot. So the mid-ambulatory stage, that next ambulatory stage, what does that look like? We're starting to see more of the weakness and more of the tightness kick in. So clumsiness, they're starting to fall a little bit more. Fatigue is starting to set in more. They're slower than their peers, their siblings, their peer group at school. We start to hear from the teachers that they're not able to keep up with the other kids. It's obvious, like on a playground or outside, they're slower. Things are more difficult from the weakness. So we'll start to see these compensations more toe walking, more waddling gait. As things are getting weaker, those compensations are coming in more, and they're just having more difficulty with those harder tasks that we talked about: running, jumping, going up and down the stairs. And we'll start to see that Gowers maneuver more. If you ask them to get up from the floor, at this point, at this mid-ambulatory stage, almost all the kids are having to use that Gowers maneuver, that kind of slow walking up their thighs, and then using that back extension and neck extension to help get them up from the floor to a vertical position. So what are we doing at this stage, at this mid-ambulatory stage? We're monitoring often. What is their function like? And I mean, I'm talking to the parents more about how are they doing getting around school? Are they having any difficulty getting in and out of the car? What about stairs? Is the child's room at home on the second floor of a house? Do we need to consider, is there any way that we can move the child's room down to the lower floor? So just general function, are they still able to do the things that they were doing before? And if they're not, how can we help with that? How can we show them how can we show the child, but also the parents, different ways of doing things? MMT is manual muscle testing. PROM is passive range of motion. So we're looking at manual muscle testing. So maybe every couple of months, I'm testing their strength just to get an idea of where are the weaknesses, and I want to focus on those areas in terms of helping them out. So again, not necessarily if I'm seeing more weakness in an area, I'm not focusing on strengthening, but that's where we need to be careful of compensations or falling or other ways of doing things. And then passive range of motion, where are they starting to get tight? And we don't want to just look at this. A lot of times as physios, there's a tendency to just look at the lower extremities or just look at walking. And I think even at this mid-ambulatory stage, we need to start looking at the upper extremities as well, because we're going to start to see some tightness in the upper extremities, and we don't want to wait until it's too late in the finger flexors or the wrist flexors. If we address these things early in terms of stretching, it yields a much better outcome. So continuing the parent and client education, increasing the stretches where needed. So there's some fantastic websites on a variety of places. Cure Duchenne, the organization that I work with, has an excellent website, and there's a tab on that website called Care, and there are videos and also PDFs on various stretches. So on a lot of these places where you'll see resources for stretching, there's usually like 6 to 8 different stretches that are the most common, that tend to get tight the most. But really having that physiotherapist look at that range of motion on a fairly regular basis can help us pick up other muscle groups that can be tight, that are not listed in those other resources. So continuing the use of the night splints and the AFOs, and I think that's where this becomes the most important, to make sure that we have that on board at this time, because this is where the calves are going to get a lot tighter. The tighter the calves get, the worse the balance, the more difficult it is to walk, and also the more energy expending it is to walk. So it's all about energy conservation as well. So anything we can do to make things less difficult or less energy expending. So I put at this mid-ambulatory stage, assess the need for assisted mobility. So that can be a manual wheelchair for long distances. That can be like an electric scooter, something for long distances. That's where I hear the most from parents, from teachers, that, yeah, they're doing pretty well, but they have trouble with long distances. It's really hard. We have to either stop and take rest breaks often, or they're not included. They're not included in the activities. Just, if they're going to go out for a long day of walking, sometimes the parents will just opt not to take the kids because it's just too difficult. So having that assisted mobility for those long distances, for those days or those times when that they're going to be walking a whole lot, we want to try to utilize that assisted mobility, that manual wheelchair, that power scooter. And then school consultation. You want to make sure that everybody's on the same page. So reaching out to the school, making sure that who's ever coming in contact with the school, the teacher, the principal, the physical education coach, whoever's in the school, making sure that they understand the basics of Duchenne. That again, this child is not being lazy. They're not requiring strengthening. That's not going to help them. There are a lot of really well-meaning people in the school, but they just don't have an understanding of what Duchenne is, and the importance of modifying the activities and not having them work harder. So the late ambulatory or transitioning stage, this is the time where we see the highest incidence of fractures. So a lot of these compensations, a lot of these difficulties, whatever the child was using to get up from the floor, to walk. This is where these things are failing. And um, uh, this is a stage where things really need to be paid attention to, because again, it's where the highest rate of fractures can happen. But also this is very difficult for the parents, because in our society, a lot of times walking is considered normal. And if you use a wheelchair or you use an assistive device, that's looked at from society as being abnormal. And that needs to change. It's about maintaining independence. It's about maintaining um, uh, social interaction, and however we can do that, and however we can maintain that. So using that assistive device more, be it a power wheelchair or a power scooter, so that the child, the young adult, can keep up and do the things that they like to do, using that equipment, not looking at it as a failure, but looking at it as a way to continue independence. So at this stage too, we're seeing more weakness, not just in the lower extremities and with walking, but greater difficulties in upper extremity things as well. So reaching overhead, brushing teeth, basic hygiene, dressing, showering and bathing. So how can the physiotherapist, how can the occupational therapist help with these activities? But this is what we're seeing at the late ambulatory stage. Things are becoming more difficult. And as they're sitting more in the manual wheelchair or in that powered mobility, we're starting to see more contractures as well, both in the lower extremities and the upper extremities. So making sure that we're addressing those things as well. So we're doing at this stage, the physiotherapy is and occupational therapy is still very important, but the focus is a little bit different. We're working more on stretching. Again, we're looking at how can we maintain independence as much as possible. And then addressing those respiratory needs, the weakness, the lack of dystrophin that contributes to weakness is not just in the muscles to walk or to lift things or do things like that. The cardiac muscles and the respiratory muscles as well become weak. And so there are things that we can intervene as well, and we can help with too. There's something called breath stacking. Very simple. You don't need any equipment for this. It's very easy to teach. And there's some YouTube videos. I put a link on here, but if you just search in YouTube under breath stacking, there's a whole bunch of videos, and they're only, most of them are like 2-3 minutes long. And basically what you're doing is, as these respiratory muscles, the muscles for breathing, to take a deep breath in and take a deep breath out, become weaker, we need to work those as well. And so it's an activity where you're taking a deep breath in, holding it for a few seconds, trying to take another breath in on top of that, holding it, one more breath on top of that, holding it, and then blowing it out. And so it's just trying to combat those shallow breaths. Again, we can go into this a lot longer, but if you watch the videos, very simple to learn, and very simple to implement. So at this late ambulatory stage, certainly we want to be addressing power mobility, but hopefully we have something in place by now, because it's getting a lot more difficult for those long distances. And then assessing stander options. Michael, do you guys have, so we call them standers here, where it's like passive, it's a piece of equipment to help with passive standing?
We do. They're probably not as common in America, but most of our boys, depending, also have access to the F5 Permobil, the standing chairs, and many
Great.
use them as the stander. So we're
Great.
getting our first one in 4 weeks, and we plan to use that as our stander.
Okay, so that's fantastic. So there are standalone stander options that are, just a stander, but I love if it can be incorporated. It's I know here in the US we have the Permobile F5 Stander too, and for those that don't know, it's basically a power chair that has actuators, and it has an electric stander built into it. So it's at a you use it like a regular power wheelchair, but then you press a button and it comes up to a standing position. There's safety mechanisms, there's knee blocks, and there's straps so that the guys don't fall out. I like this even better because you don't have to transfer to a different piece of equipment, and you can really utilize it from a functional perspective. If they want to get something from a higher up position, that helps with that. And I think there's a huge psychosocial component to that, to being on level with your peers. So if all of the guys friends in school are standing and they're up here and they're sitting down in a wheelchair, that really can have a psychological effect on the person. So having the stander built into the power wheelchair, I think, is fantastic. And then again, continuing with the school consultations. So talking with the school, how are they doing? What are they having difficulty with? What do we need to address? And then that non-ambulatory stage, it's the non-ambulatory stage, obviously, is that point where they're not walking anymore. The physiotherapy is just as important. So sometimes there's that thought that, well, they're not walking anymore, so there's not really anything else that needs to be done. But it's still just as important at every single stage. It's important. And it's also important to remember that the frequency of the physiotherapy, that varies throughout different stages. Sometimes if things are really stable, and we have a lot of good things in place, the parents understand what's going on, they're doing stretching, hasn't been a huge change, I might see the kids once every 3 or 4 weeks, checking in, making sure they're doing okay, how's their equipment doing, how's the stretching going. If there are changes, like if they're going from an ambulatory to a non-ambulatory stage, if they're having difficulty getting in and out of the car, if something changes, I might see them more frequently. So the frequency of physiotherapy can change also in terms of the needs. But at this non-ambulatory stage, we're doing a lot with stretching. I've talked to the guys that are non-ambulatory, and I've talked to them about stretching just from their perspective. I ask them, do you feel like it's beneficial? Do you feel like it helps? And overwhelmingly, they say absolutely. Sitting in one place is just horrible for the body. It's just, our bodies are not made to sit in one place and not move around. So for them, getting that range of motion really makes them feel more comfortable. And it can also help them to do things. If we can try to prevent those elbow contractures or those wrist or finger contractures, it can help them to do things with their upper extremities. We're also looking at scoliosis and spinal mobility as they walk less, or they discontinue walking and now they're sitting for large parts of the day. That's when the incidence of scoliosis goes up. So we have to make sure that not just that everything works in their power wheelchair or in their wheelchair, but what does their sitting position look like? Are they supported? Are they sitting in a midline position, or are they collapsed to one side? And do we need to address that through laterals or supports? Really looking at that upper extremity. So focusing on the range of motion, what are they able to do? How can we help them to self-feed? Do we need to get them a tray for the wheelchair so that they can use a laptop or do different activities on that tray? So really focusing on function and independence, and this requires from the parent side and from the physio side A lot of problem solving, because there is the difficulty of contractures, there is the difficulty of weakness, but there's a lot of equipment out there, and it's an amazing time with technology, with Bluetooth, with switches, with controlling things through eye gaze. So there's a lot of different things out there, technology that can help these guys, these men, to continue to stay in school, to continue to be employable, and to continue to do the things that they like. And just the last thing, just reiterating that it's important to address those, maybe some of those muscle groups that we didn't have to address before when they were walking. So continue using the stander if it's safe and if it's comfortable. Equipment is a big part here. So do they have the power chair? Can they get that has the stander? Do they have bath equipment? So anything that they're going to need for bathing. What do they need for transfers, whether it's a sliding board or a patient lift, or something to help get in and out of the car, bracing for the hands and the wrists. So any type of equipment, that's where at this non-ambulatory stage comes into play the most. And assistive technology, like we talked about, so much out there. It's amazing just in the last 5 to 10 years, what can be done through assistive technology at home, at school, at work, Bluetooth, so that they can operate a computer through the use of the joystick of their wheelchair, voice recognition software, all different types of bathing and toileting equipment. In terms of the hands-on therapy, I think aquatic therapy is one of the most beneficial things at this stage, because obviously they're not walking. It's much more difficult for them to move around, and gravity is not their friend. So getting in the water unweights them. There are things, and they can move around, and there are things that they can do in the water that are much more difficult in land therapy or mat therapy, whatever we want to call it. And then the respiratory exercises as well, making sure that we're addressing those respiratory exercises. And then the last thing I want to say is I think it's really, really important from the physiotherapy side, addressing everything, life purposes and goals, not just focusing on the physical stuff and coming in and doing the stretching or maintaining walking or getting up from the floor. Those things are great, and we need to address those things, those physical things, but really talking to the person and talking to the family about what's important to you. Not every child wants to go to university. Not every child wants to work, but if that's a goal for them, how can we as physios help to make that happen? And also placing the importance on those things. A lot of these guys, I see it here in the US, a lot of these guys, the expectations from the outside community are not high. And a lot of them are sitting home once they stop going to school. They're sitting home and they're watching TV, they're watching YouTube videos, they're playing games all day. And that's fine. There's a place for that too. But if we can help them go to university, or if we can help them work from home, even with limited physical mobility, how can we make them that happen? Everybody wants to have a purpose in life, and everybody wants to have a reason for getting up in the morning. And somebody that has Duchenne is no different. And so we need to place more importance on that and asking them, what do you want to do? What's important to you? And addressing things. These guys are living longer too. The life expectancy is much longer. So dating, getting married, things like that, having romantic relationships are part of the equation too, and addressing those things as well. So that's kind of the role of therapy and in the different stages. Here's Jennifer is the other physiotherapist that works with me at Cure Duchenne. We always try to be as available as possible, and we're really good about getting back to people quickly. Here's our email. I'm on Facebook as well. And so anybody, if they have questions, certainly we're going to address these things here today, but if things come up or we can help in any way going forward, please reach out to us. We're very passionate about what we do and helping this community and improving the lives, not just of the guys with Duchenne, but the families as well. So we're happy to be a resource whenever possible.
Thanks for that, Doug. That was amazing. We've got a couple of questions here. We've allowed a little bit of time. So the first one is from Neha, who has asked, what would a typical PT session at clinic look like activities, games, etc.? And that's outside of assessment and stretching. And she's talking for the early ambulatory and mid-ambulatory stage.
Sure. So certainly stretching is typically a big part of a therapy session. So I still will work on things like balance. So there are a lot of activities that I work on as long as we're not stressing their bodies or working on a lot of strengthening. So balance activities, not just in standing, but sometimes in like half kneeling. I'll still work on those things because I think that it's important without stressing out their body. I do a lot of respiratory activities as well. And these are kids, so it's important to try to make these things in games. So maybe we'll sit across from each other at a table. I'll use a straw and try to pick up a cotton ball or something with that straw and then put it in the cup. So they're working on those respiratory activities, or blowing something. Who can blow this little folded up piece of paper or wadded up piece of paper across the table first. So these different respiratory activities, both on the inhalation side and the exhalation side, where we're just making it into games. Certainly if there's a pool that's available, I love respiratory therapy. Stationary bicycle on very little resistance to no resistance. I want it to be easy for them to do, but I still want that range of motion component and that cardiac component. I want to try to get their heart rates up a little bit, because there's benefits to that part of it as well. So really, we're focusing on mobility, aerobic, trying to get their heart rates up, and doing things that they enjoy. And so balance. So it sometimes it'll look different at different times, but I'm just avoiding those typical therapy sessions where we're stepping up on a step or going up and down the steps, or really working heavily on balance to where it's really difficult for them.
Wonderful. Daryl has asked, sorry, let me bring it up. Daryl from Sydney has his son Lachlan, 13, late stage ambulatory, loves water, and we take him swimming weekly with a sports physio. We have spoken to them, however, they have a tendency to try to improve the situation. So I think he's alluding to the strengthening exercises. And he's asked, can you recommend things to do in the pool and not that in a program?
Yeah. So Daryl, do you mean just like things that you can do in the pool with him?
No. So hope you can hear me okay. But
Yeah.
look, he's with a sports physio, and they do a range of things there, even though we've spoken to them and they've read up on Duchenne and we've sent them some various info. But they like to record things by how you improve, say, number of repetitions of things, right? And we have to keep sort of correcting them back on that. And their reports tend to read the same as well. So they'll benchmark against 5 reps of something and then go, well, by 6 months, we'll be able to do 10, and we're going, no, that's not it, right? So, we sort of emphasize the need for rest and just sort of more gentle stuff, but they kind of can't help themselves because it's sort of, what they do with other clients, right? So non-Duchenne. So really just kind of, if there's a program of better things to do, of things definitely not to do. And the second part of the question, which I know that you can't answer, is they write reports which help us get funding, right? And so that relates to those benchmarks that I've just spoken about. So yeah, look, that's my question now.
Yeah. No, and I can address both those things. First of all, what I recommend to parents, if you've done all of these things to the physio, like you've given them resources, you've told them about lack of stretching, things like that. I'll recommend to parents to try to find a different physiotherapist, because it's important. I don't expect every physiotherapist to know about Duchenne. I mean, it's a rare disease. I've taught physiotherapists that have been pediatric therapists for 20 years that have never worked with somebody with Duchenne. So if they don't know about Duchenne, it doesn't necessarily mean that they're bad physiotherapists. But if they won't listen, or if they're not willing to learn, then I kind of want to sort of slap them upside the head. So I understand the funding side of it, and to me, it seems like, at least here in the US, that the funding sources have gotten better at understanding progressive diseases, that they're not, whether it's Duchenne or something else, that we're not going to see improvements. It's more about, slowing things down or kind of keeping things where they are. So the idea of improving the number of repetitions or improving the strength, it definitely shouldn't be that way. It sounds like you've given them resources. We have an online course at Cure Duchenne that they can take as well. But if they're just kind of, that's what I'm saying. When we come out of school as therapists, we don't typically, like when we come out of physiotherapy school, most of us don't know about Duchenne. And so we are trained to strengthen. If something's weak, you strengthen it, especially if it's a sports physio, that's going to be their focus. So I would say, they're potentially doing more harm than good. So I would maybe try to find somebody that is either more willing to learn about it or knows about it. And I'm also happy, if they don't want to take the course, I'm also happy to be a resource for them too. So if they want to reach out and talk, and I can just explain, that that's not the approach that we want to use.
Perfect. Can I just, sorry, Doug, jump in? That course that you're talking about, online course, is there a link you can share?
I can send that to you, Daryl. My physio took that course last year, so I can get that link for you and email it to you tomorrow.
Great.
Yeah.
No problem.
And we are also, guys, just so you know, Jennifer and I, this was just about 4 days ago, we did a parent course. So we have this online course for physiotherapists that's like 4 hours long. We did about a 45-minute or an hour course that's going to be online, and there's no cost to that. It's for the families, and it's talking about a lot of what we talked about. We just recorded it like 4 days ago, so it'll probably be ready in about a month, but it'll be on our website as well.
Thanks, Doug.
So Doug, I've got a question from Nurbo here. He's saying, and I'm going to roll Nurbo's question in with mine, and Nurbo, you can jump in after you're ready here, because they're very similar questions. So he's written, for stationary bikes, how much duration would you recommend? Now, my question is along the same lines. I mean, you spoke about earlier about that sweet spot between not enough and too much. And I've always read the studies, the use it or lose it studies and whatnot. So, I mean, once in my situation where the boys become non-ambulatory, we're so desperate to keep these kids as active as possible, doing as much as we can. For us, we do probably swimming 3-4 times a week with myself, or he's still got an electric trike that he rides, pedal assist, So, I mean, what is the line between, exacerbating muscle loss and maintaining muscle loss? And, like for me, if he's riding his bike, I worry, is he holding his arms out too long on the handlebars and whatnot? Where do we sort of draw the line at saying, okay, we might be going a little bit too far with, trying to keep them active?
Yeah. Gosh, I mean, it's such a difficult question because it varies, it varies with everybody. And this is where the research that's currently being done is trying to figure out, is how much is too much. And it's unfortunately, my answer is more subjective, right? There are approximately 4,000 or 5,000 different mutations of Duchenne muscular dystrophy, and every one of those, I mean, even if you take guys with the same exact mutation, they react differently physically, and they look differently, and they have different endurance. So a lot of it is subjective. Like, we have to know what we know about not overusing and supporting, like if they are riding the tricycle, if his arms are out there, trying to get support under the arms. But a lot of it is trying to see how the child responds. So I would say, in terms of, just if I had to like kind of ballpark it, like a stationary bike, if there's no electric assist to it, if it was just a three-wheeled stationary bike, a three-wheeled tricycle, or a stationary bike, I would probably do no more than like 5 to 8 minutes at a time. If there's like, it's a trike, like it sounds like your son has, where it's an electric assist.
Yeah.
I mean, this is why the self-awareness part of it is so important, because it's kind of checking in with them during the activity, but also checking in afterwards. So if you guys went out and you did a bunch of, you were swimming in the pool or at the beach, or you went out and rode the bike, and then that night he's just absolutely exhausted, or the next day he's really sore and he's cramping, then that's too much.
Yeah.
So it's hard to say exactly, this many minutes or this much resistance, or for this, it's kind of going by, well, how did my son respond to that? Did it seem like it was okay, like we had fun, and then the next day, like he was doing okay, or did it make him more sore, and we need to back off of that a little bit?
Yeah, it makes perfect sense.
Yeah, it's so, I think it's so frustrating for you guys, and it's so frustrating for us, because there aren't, with these exercise questions, there aren't exact answers, like, do it exactly this way or do it exactly that way. And I hope we get to the day where we can kind of hone in on that better.
Well, I think you've said it correct before. I mean, Duchenne is just such a wide spectrum, and it's so different. These boys, either have, environmental or genetic factors that alter their course of the disease, and it's really not one size fits all. So yes, I agree with you. But yeah, I think that is monitoring signs of fatigue afterwards is probably the best answer, or pain.
Yeah.
So Nurbe, is there anything else you need to add?
No, that's fine, mate. I do understand. Yeah, because we don't use the bike, because our son never was able to ride a bike. And we supplement that with more of swimming, giving him more time in the pool, the heated pool as well. But stationary bike was something I've never considered. until you said, Doug. So that's the reason I asked.
Yeah, and more there are these stationary bikes that have, you know, that you can get this electric assist. And so if
Yes.
you start slowing down or whatever, so it's, you know, in that sense, it's helpful in the mobility of getting on that bike, and, you know, we're going through the range of motion while they're on the bike.
Thank you.
Perfect. I think that is it for questions, and I think we are coming towards the end of the time. So if there's anyone has any more questions, now would be the time. If not, I think we're just going to end it here. Doug, I would like to say a huge thank you for being with us tonight. We're very thankful to Cure Duchenne for, you know, firstly putting together the resources and the commitment to have a Duchenne specific physio, and of course finding someone like yourself who's just so passionate about it. And you know, I've got lots of friends in America, and you know, you're very well regarded among them, and you've gone above and beyond for many of these families on many occasions.
Thank you.
We hope one day to see you over in Australia, perhaps at a conference in the future. And yeah, we really appreciate you, Doug, and thank you so much for being with us tonight.
Yeah, thank you guys. And yeah, I appreciate you asking me to do this. And you know, again, if there are specific questions,
well, yeah, so I think it's also important to mention others. So Doug runs the PT therapy group on Facebook. It's a great page for parents. And, you know, and he's always very quick to answer and respond, either him or Jennifer, in getting back to parents on that, which is really a great resource to a lot of us. So I suggest to a lot of people to, if they're not on that group, to maybe consider joining. And yeah.
Yeah, it's called Duchenne Physical Therapy.
Duchenne Physical Therapy. All right, so we're going to end it there, guys. Doug, thank you again.
Michael, thank you, and nice to meet all of you. And yeah, hope to see you in person someday.
Yeah, and yeah, same. And Chrissy, thank you very much for all your support tonight.
You're welcome. Thank you, Doug.
All right, guys.
Thanks,
You're
Michael,
welcome.
for organizing so
everyone.
much.
Yeah. All right,
Take
Doug,
care,
thank
everybody.
you. And I'll touch base with you after in the next few days. Thanks, Doug.
Okay, sounds good. Bye-bye.
Bye.